Hi, my name is Bree Cowart. This is for class nursing 7348. It's November the 7th, 2021, and this is my presentation on stimulant use disorder. The DSM-5 criteria includes a pattern of amphetamine-like substance, cocaine, and other stimulants, and use that leads to clinically significant impairment and distress. And it lists two of the following criteria within 12 months. This includes craving the substance, taking it in large amounts, and also building a tolerance using the drug. The DSM modifiers include early remission, late remission, and in a controlled environment. So early remission is following the full criteria for stimulant use disorder, and then with no criteria within a 3 to 12 month period. The late remission is showing no criteria are met within a greater than 12 months period. And then in a controlled environment is where such as substance-free jails, therapeutic communities, and locked hospital units where they have no access to the drugs. So how do you determine the severity? The severity is based off mild, moderate, and severe, and it's the amount of symptoms that are present. So you'll go back and look at your DSM-5, look at the symptoms that's listed. There's a total of 12 symptoms, and then you'll base it off of that. So mild is presence of 2 to 3 symptoms, moderate is the presence of 4 to 5 symptoms, and severe is the presence of 6 or more symptoms. So tolerance is defined as a need for markedly increased amounts of the stimulant to achieve intoxication or desired effect. It is a markedly diminished effect with continued use of the same amount of the stimulant. So they need more and more of the stimulant to create that same effect of high. So I'm going to specifically discuss the origins of amphetamines. It was developed in 1800s from a Roman chemist. It was synthesized from a chemical compound that Mei Hong, a plant found in China. In 1920s, it was first noticed to dilate the bronchial sacs of the lungs and clear breathing passages, which led to a benzodrine inhaler, which was introduced in the market and was over the counter. In 1962, the FDA estimated more than 200 million amphetamine pills were in circulation in the United States. The annual sales have grew significantly, and by 1965, the inhalers were finally averted to a prescription-only basis and removed from over-the-counter. A wide potential for abuse was finally determined, and the dangers of amphetamines were finally being recognized, causing authorities such as the FDA to take action. So what are the street drug names for meth? It includes speed, crank, ice, uppers, crystal, pineapple, skippy, Ritalin, kibbles and bits, R-ball, the smart drug, and vitamin R. If you look at this chart, it shows the different stimulants. Some of the effects that you get from the stimulants, such as euphoria, increased confidence, rapid heartbeat, reduced appetite, sexual arousal, mood swings, anxiety, and dehydration. And there's different types of stimulants, such as the amphetamines. Caffeine can be a stimulant, cocaine is a stimulant, ice, nat, nicotine itself are all stimulants. So what are the diagnostic features? Stimulants come in the form of pills, powders, rocks, and injectable liquids. The route of administration, it can be swallowed, smoked, snorted, and injected. You can develop stimulant use disorder rapidly with IV or smoked administration. It's a very highly addictive substance. As far as with admissions into the hospital, primarily 66 reported smoking, 18% reported injecting, and 10% reported snorting. They also found that injecting and smoking increased your risk of rapid progression into stimulant use disorder, and oral form and snorting showed more of a gradual progression. And the stimulants produce a sudden sensation known as a rush or a flash, and this is what the drug seekers are looking for as they use the drug. The prevalence of use of stimulants includes amphetamines and cocaine. So if you look right here, amphetamines is mostly used by people that are aged 18 to 29 years old. It's more likely that males are to use 3 to 1 compared to females. And majority of patients are white or African American. As you know, anybody can really use it, but this is what they've seen as majority. As far as with cocaine, majority of your patients are also in that 18 to 29 year range, and they also found that Native Americans and African Americans use cocaine a little bit more. Stimulant use disorder affects all racial, ethnic, socioeconomic, age, and gender groups. Chronic use of cocaine was found to impair cardiac left ventricular function in African Americans, and approximately 66% of individuals admitted to primary methamphetamine-related disorders are non-Hispanic, followed by Hispanic 20%, 3% are Asian and Pacific Islander, and 3% are non-Hispanic Black. Risk factors for stimulant use disorder include having comorbid bipolar, schizophrenia, antisocial personality disorder, and other substance use disorder. Childhood conduct disorder, or RCD, is also associated with later development of stimulant use disorder. Predictors for future cocaine use includes prenatal cocaine exposure, exposure to community violence during childhood, and living in an unstable home environment. So laws against drug use. According to the Controlled Substance Act, which was passed by Richard Nixon, this allowed federal jurisdiction over specific plants, drugs, and chemical substances. This established a classification of scheduling systems for the drugs. The Anti-Drug Abuse Act of 1986 and 1998 also addressed the differences between powdered and crack cocaine, with 100 times more powdered cocaine than crack cocaine to receive the more severe minimum sentence. The ratio was later reduced from 100-1 to 18-1 in 2010. So laws against the use of stimulants, there's three different kinds. There's possession, drug trafficking, and manufacturing. So possession, you can have a simple possession where if you have a small amount of substance, it's considered a misdemeanor, and you can get up to a year in jail and a fine of at least $1,000. And this penalty varies by the state. There's a possession with intent to distribute, where if you're found with larger quantities of the substance, it's broken into smaller bags, or if you have a scale or large amounts of cash, there's definitely heavier consequences for this. Drug trafficking is a felony, and the penalties depend on the substance, amount of drug involved. If you're caught with powder cocaine and involving 5 to 5,000 grams, there's a 5 to 40-year prison sentence with a fine up to $5 million. Second offense penalties for these drugs range from 10 years to life in prison with a fine up to $8 million. Manufacturing is making or producing the substance with intent to sell, and it definitely has fines and sentences associated with it. But if you're found near a school or a playground, your fines and sentences are doubled. Stimulant use disorder can develop as early as 1 week. Abuse is often associated with a pattern of binge use, sporadically consuming large doses of stimulants over a short period of time. Heavy users may inject themselves every few hours, continue until they have depleted their drug supply or reached a point of delirium, psychosis, or physical exhaustion. During heavy use, all other interests become secondary to recreating the initial euphoric rush. So, according to the APA, the first average age of use is from 12 to 25 years old. Their first regular use is around 23, and people may just start to use to control their weight or to improve performance in school or due to work or athletics. And that's kind of where they feel like, okay, I can do this just for a short term, but then it becomes more addictive and turns into a long-term issue. So if you look at this diagram over here, this is kind of what happens to the neurotransmitters in the brain with meth use. So first, it disrupts the dopamine neurotransmitter system. It causes excess release of dopamine. It overwhelms the process of reuptake. It overwhelms the process of enzyme breakdown. And then it causes dopamine to leak out of the vesicles. So you have an excess of dopamine, which causes hallucinations, it causes paranoia, it can cause delusional thoughts. And so a lot of times when you have people that chronically use meth, they have psychosis. And it can, even with long-term use, they can continue to have psychosis even after they stop using the drug. Here's a great video of how drugs and especially stimulants can affect the brain. I think this pinball machine really illustrates it in a very easy way for you to remember. So according to the DSM-5, stimulant intoxication includes 2 or more of the following symptoms that develops during or shortly after stimulant use. This includes tachycardia or bradycardia, pupillary dilation, elevated or lower blood pressure, perspiration or chills, nausea or vomiting, evidence of weight loss, psychomotor agitation or retardation, muscular weakness, respiratory depression, chest pain or cardiac arrhythmias, confusion, seizures, dyskinesias, dystonias, or even a coma. And when you make this diagnosis, you want to specify which stimulant they are using, such as amphetamines or cocaine. And then also you want to determine if there's any perceptual disturbance associated with it. So are they having any hallucinations associated with their intoxication? Stimulant withdrawal is definitely, you'll see in practice, majority of them are always in a dysphoric mood, and they have 2 or more of the following several days after they have stopped the substance. They'll have extreme fatigue, vivid or unpleasant dreams, insomnia or hypersomnia, increased appetite, and then psychomotor retardation or agitation. So diagnostic markers, so what are some things that you can look at in the lab work of a patient who you suspect may have cocaine or meth use? So with cocaine, the metabolite benzoleucogene of cocaine remains in the urine for 1 to 3 days after single dose and may be present for up to 7 to 12 days in individuals who have repeated dose. Mildly elevated liver function tests can be present with associated alcohol use. Discontinued chronic use of cocaine may be associated with EEG changes suggesting persistent abnormalities, alterations of downregulation of prolactin, and then downregulation of dopamine. For meth, it's a very short half-life, and it can be detected for 1 to 3 days and possibly up to 4 days. And then hair samples can be taken to detect amphetamine stimulants for up to 90 days. So with stimulant use disorder, you definitely always want to make sure you do some differential diagnosis just to kind of rule out other things. So primary mental disorders are not associated with substance abuse. So you can rule that out very quickly. If they're positive for meth or for cocaine, that's more than likely what's causing their mental disorder. So you can rule out regular mental disorders based off of their positivity. PCP intoxication may cause a clinical similar picture and can only be distinguished by a urine drug screen positive for amphetamines and cocaine. So PCP would show up differently on your urine drug screen. So that would definitely, if they're positive for amphetamines or cocaine, that would definitely have you rule out the PCP intoxication. Stimulant intoxication and withdrawal are acute. To be diagnosed with stimulant disorder, you must chronically use them for 12 months. So, just because someone comes in and they have used in the past 2 days doesn't mean they have stimulant use disorder. They definitely have to have that use for a full 12 months in order to be diagnosed with it. So there are definitely some consequences to stimulant use disorder and how it affects your body. Intranasally, it can cause you to have nosebleeds, sinusitis. Smoking can cause coughing, pneumonia. IV use can cause HIV, hepatitis, lung infections, weight loss. Chest pain is common with people who use cocaine. It can cause myocardial infarctions, palpitations, arrhythmias, sudden death. Pregnancy, it can cause irregular blood flow to the placenta, and also low birth weights. It can cause neurocognitive impairment, which is common with chronic meth use. It can also cause tooth decay and mouth sores. And people who use these substances are more likely to be involved in theft, prostitution, and drug dealing. So if you look at this picture right here, it shows the effects of cocaine on the aged heart. It shows inflammation of the heart, muscle lining, and valves, which causes myocarditis and endocarditis. It thickens and stiffens the valves, and it makes you have a thickened heart wall. Some screening tools that you can use in practice includes the CAGE questionnaire, but using stimulants in the place of alcohol. Rhode Island Readiness for Change questionnaire determines, are they ready for change? Are they ready to quit? Substance abuse and screening tool, identifies how often they're using the substance, the frequency, their route of administration, and how many years. So there's definitely a lot of treatment options for stimulant use disorder. This includes medical clinics, mental health programs, inpatient and outpatient addiction programs, and treatment centers. Counseling and other treatments that focus on behavior are currently the most effective treatments. This includes contingency management, where they get rewards for good behavior, motivational interviewing, cognitive behavioral therapy, and community reinforcement approach. There is still no FDA-approved medications to treat stimulant use disorder at this time. There is some evidence, however, that some mental health medications can be helpful for some people. These include SSRIs for depressive symptoms, antipsychotics for the psychosis, and you definitely want to treat the symptoms. An example of a medication that can be used is bupropion or Wellbutrin. It affects the dopamine and norepinephrine levels, and it has that activating response to help with the fatigue and psychomotor or retardation. You do want to watch out though, because it does affect the dopamine levels, so it could possibly cause increased hallucinations, paranoia. So if you do have a patient then you may want to stop that medicine and try something else. You also want to check for seizure history, because Wellbutrin can increase your chance of having seizures. So if they do have a seizure history, you would want to try a different medication. All right, some people use stimulants to help manage other areas of their life. So if they're homeless, they have no jobs, they're not able to be around, that might be the reason why they're using. So you definitely want to address those areas of their life, which can help them reduce the amount of stimulants that they're using. This includes helping them find housing, employment, connecting with others in the community, helping with a 12-step support system or program, and then addressing their health issues. There is also some evidence that exercise can help reduce stimulant use disorder and improve health. So let's look at the evidence and some of the evidence-based practice. One random controlled treatment study in 2020 found that both Abilify and risperidone were effective for patients diagnosed with amphetamine-induced psychotic disorder. However, risperidone had a greater effect on positive psychotic symptoms, while patients with negative symptoms may respond better to Abilify. So that's one way that you can look at it. You kind of just weigh what symptoms is this patient having more of, and this is kind of how you would direct your treatment. The next article, according to Ronsley 2020, psychostimulant treatment has a similar pharmacological rationale as other evidence-based substance treatments like nicotine replacement opioid agonists. The core review by Costells and colleagues found significant positive results for sustained cocaine abstinence and found positive, but insignificant results for reduction in use. Further research is needed. So in this article, it found that psychostimulants actually helped them sustain cocaine abstinence afterwards. So it's not necessarily what we do in practice right now, but it is showing, changes in research and how we're learning to help these people. Here's a list of additional resources that can help you learn further about stimulant use disorders. One thing in practice that we always like to teach is prevention. So here are some ways that we can help prevent from substance abuse disorders, such as stimulant use disorder. And this is increasing the proportion of adolescents who think substance abuse is risky, increasing the amount of people who seek help for mental health, and decreasing the mental health stigma. So that way more people get seen, because majority of the people that are using these substances are doing it because of their mental health. It's not all of them that are doing it that way, but a lot of them are. So by understanding this presentation and how I can impact my future practice, I can adequately diagnose, plan, and treat stimulant use disorder. I can correctly identify stimulant use disorder as well as intoxication and withdrawal in practice. I can educate my patients on stimulant use disorder and the effect it has on the brain and body, as well as the negative consequences associated with family, work, and social obligations. I can educate patients on the treatment options to improve outcomes, and I can connect the patient to the correct resources to help with sobriety and the discontinuation of use. With the end goal of this presentation, we, as practitioners, have the obligation to increase the proportion of people with substance use and mental health disorders who get treatment. At the end of the day, we're helping meet our Healthy People 2030 goals, and that is improving health outcomes. Here are my references. Thank you so much. This concludes my presentation. I hope you have a wonderful day.